It was an easy role to chair the Sentinel trial because with people like Axel, Raj, and Sushil and Samir, was a very, very easy role. We had really superb investigators. So I'm going to talk about an interesting concept. First, I'll set the stage, and then I'll dive a little bit more deeply into something called shared decision-making. You know, interventionalists have ADHD. We're hyperkinetic. We have to do things. But the idea of communicating with patients and trying to reason with them in terms of what is the right therapy maybe is not one of our best skills. But I must say in the future, this is something we're going to have to incorporate into our ability to be able to deliver new therapies. So, and I'm learning about this, and I always like to be challenged with new things, and I'll attribute the correct people who have really contributed to this field. So a little bit about background, and you've heard much of this, so I'll go through it quickly. First, key points about cerebral embolic protection. I lived through the beginning of TAVR. Strokes were feared and really acknowledged as a periprocedural complication. They were somewhat exaggerated, perhaps. They are a random, unpredictable, devastating event when they occur. Over time, I do think that stroke frequency after TAVR has declined somewhat, and certainly it is non-inferior to surgery. And I want to keep emphasizing that. It is non-inferior, maybe superior, but non-inferior to surgery in the recent randomized trials, including Partner 2A, and including the CERTAVI study in intermediate risk patients. Nevertheless, stroke risk is still significant in the modern era. It's not importantly affected by operator experience either. This is an interesting analysis of 5,000 patients with contemporary TAVR devices with an overall adjudicated stroke frequency rate of about 3.5%. It is real, and it does occur, and if you do enough cases, you will see it. This is from the TVT registry, looking at over 43,000 patients in over 350 centers. These are self-reported stroke rates, but the point here is that there's an initial decline that actually isn't even significant, but after even 100 cases, your ability to prevent strokes as an operator with experience doesn't change. So you can't say that, well, I'm an experienced operator, so I will have a low stroke rate. That probably is not going to occur. These will be continued, random, unpredictable, and devastating events. We've already said most of these strokes after TAVR occur within the first 72 hours of the procedure. That is really the vulnerable period. Stroke frequency is highly definition dependent. So you'll hear numbers that are high, low, but it's all based upon how you classify it, how you do the ascertainment with neurology assessments, what are the thresholds for detecting subclinical events. There's some beautiful work that was done by the NeuroArc investigators. I have to congratulate them in trying to better define strokes and the importance of strokes. So this is a nice slide from Eberhard Grube. The dilemma, what is cerebral injury? We talk about the clinical strokes, but there are minor strokes, there are TIAs, and there are silent cerebral infarcts that we see very frequently in these patients. We don't know how these minor or silent neuro events may have important long-term consequences, particularly when we're dealing with younger patients at an earlier stage in their life. This is a published version of NeuroArc, and they did a very nice job with some new definitions to really understand the classification, application, and assessment of neurologic events. So I think this is a worthwhile document to read, but it gives you some perspective on the complexity of this area. Patient perceptions regarding the importance of strokes vary, and they can have exaggerated impact beyond the actual event frequency. This is a nice study that was done by Megan Coilwright, who's a brilliant young investigator, a structural interventionalist who works at Brown now, and she tried to define some of the patient goals for treatment of severe aortic stenosis in this analysis, asking questions like, what matters to you most? What do you hope to accomplish with treatment? What do you want to do that you cannot do now? And this was the conclusion. First, staying alive. Almost irrelevant. Only 7% said that was the priority. People don't really care about staying alive. Reducing symptoms, 15%. Well, it's nice to reduce symptoms, but it wasn't the most important thing. 30% said, I want to maintain independence. I really want to be independent. And almost half said the ability to do a specific activity, to be really functional, to be returned to a normal state. So this gives you some perspective that is really interesting in terms of what patients want, and frankly, this has to be a discussion among patients. In the elderly, a stroke is worse than death. We hear this all the time. Maintaining independence and enjoying important activities is critical in its quality over longevity. In younger, lower-risk patients, they are more concerned about mortality, of course, but they're also concerned about cognition, mental acuity, and a rapid return to normal quality life. All of these things are potentially related to neurologic events. You've heard that filters have shown impressive embolic debris liberation during most TAVR cases. We all know that. The totality of evidence from several of these embolic protection device studies with TAVR have shown improvement in clinical and neuroimaging findings compared with control subjects. And I don't want to be too device specific. There are several devices that are out there, many trials that have been done, but I was most provoked by these data that frankly was a retrospective analysis. It was a post hoc analysis of the 72-hour stroke rates. We were not powered in Sentinel to show a difference in strokes, yet there was a 63% reduction that nearly made clinical significance in the first 72 hours in the Sentinel trial in terms of strokes, clinically adjudicated strokes. And as I mentioned in this Justino, a very interesting meta-analysis, the number needed to treat was 22 patients to reduce one stroke or death. That's a number needed to treat of 22 is very substantial. So this is not a minor effect on important hard clinical endpoints. And finally, the use of CEP, either selective or systematic, should be a shared decision-making process, accounting for risks and benefits. And what do I mean about that? Well, this concept of shared decision-making, again, I'm learning, I'm being educated by Megan and others, has already been infused in the whole concept of the ACC-AHA guidelines relating to the heart team. In the first document in 2014, it said you have to have a shared decision-making approach, but I never quite understood what that meant. Now we're actually doing evidence-based analysis of what shared decision-making is within the context of the heart team. This became really more important with the recent approval of the Watchman device, where the FDA said the device is indicated for patients who have an appropriate rationale to seek a non-pharmacological alternative. And to get reimbursement, the Medicare national coverage decision was based on a formal shared decision-making interaction with documentation in the medical record discussing risks, benefits, alternatives with an independent, non-interventional physician using an evidence-based decision tool. In other words, you can't get reimbursed unless you do this if you want to put a Watchman device in the United States. Now, these are what we call preference-sensitive decisions, which means you have more than one reasonable option. Uncertainty exists in the evidence. It's not completely definitive, and patient preferences may vary, and they may be distinct from healthcare professional preferences. So even the choice between TAVR and surgery is a preference-sensitive decision. And certainly, the application of embolic protection falls into that category. There are some common myths about shared decision-making. Some people say it's impossible. Patients will always ask me what to do. We already do it perfectly. It's easy. Just give the patients a pamphlet. It's a fad. It will pass. I'm telling you, this will not pass, and this will be infused into how we communicate with patients in the future. There is a 5-step process. First, you have to name the choices. You have to explain what shared decision-making is. You have to describe the choices using a prepared decision aid, listen to what matters most to the patient, and then make a decision together using patient preferences. These are some examples of some decision aid tools that were developed for the management of patients with aortic stenosis, done by Megan. And again, we don't have time to go into too much detail about this, but it requires a formal meeting to really discuss this. So applying CEP devices with TAVR and going through this 5-step approach, after a decision to have TAVR is made, you need to discuss embolic protection as an alternative during the procedure. Explain issues like embolic debris, strokes, and what the devices are. Discuss shared decision-making as a process. Describe the choices using a prepared decision aid, risks and benefits. Listen to what matters most to the patient, and then make a decision together using patient preferences. So we have to always respect patient preferences when we make decisions. And I believe that in the future we're going to be using a much more complex, interactive, communicative approach to how we manage new devices. And I think that this concept of shared decision-making is going to be importantly embedded into the way we make decisions that are best for our patients, with a significant impact from patients on how those decisions are formulated. Thank you.